Hi, good evening everybody. Welcome to my YouTube channel. I'm Dr. Asmita Yadav. I'm a junior resident at Obstetrics and Gynecology Department, KMC Manipal. I have done my MBBS from KMC itself. I'm 2016 batch and I have started my JR-ship this year only. This is my 6th month. This YouTube channel was actually previously, I had used it for my recording my UG days in Manipal. But now I think as a PG, there lies more responsibility. And I wanted to be on YouTube. I have a keen interest in teaching and learning simultaneously. And although PG is hectic, I don't know how I will be able to do this, but one should start, right? So I hope you enjoy this YouTube channel. I will be, as today's discussion, I will be tackling cervical precancers. This will be a brief overview. I will not try to go into much detail because these topics, there are so many guidelines, there's so much that has already been done, and there are people much more qualified than I am to go into detail. This is just a small attempt in learning myself and maybe along the way teaching others also. In this session, if you feel that I have relayed any wrong information or my facts are not clear, please let me know. I'm also a student, so please let me know in the comment section, and if you like the video, please subscribe to my channel. Okay, so we will be discussing cervical precancers today. Now, why is carcinoma cervix or everything leading up to CA cervix is important? So first, you can see this lady here. She is, I don't know if you guys know HeLa cells, immortal cells, Henrietta Lacks. I am not sure if I'm pronouncing the name correctly, but this lady here, so little backstory. At John Hopkins Hospital, she had gone with the vaginal bleeding, and the doctor treating her had taken some sample cells. You know how we take biopsy these days and sent to histopath lab, and in that lab, usually whatever cells were preserved, usually this was a common routine practice. Those other cells that they used to store would die, but her cells did not die, and they kept on replicating and becoming more. To the fact that till date, her those cells that were taken from her has been used for multiple scientific research and all. Later on, definitely there was a big issue that John Hopkins did not obtain proper consent from the family and everything, and in modern era that would not have been possible, but science definitely tells us a lot, and in this case cervical precancers is a part of women's history. So starting on that note, let's start. So what is cervix? Cervix, so I'm hoping everybody watching this video is familiar with basic female anatomy. So in your female reproductive system, there is uterus. Once again, let me get the highlighter. There is uterus, there are fallopian tubes, ovaries, and the lower part of the uterus going into the vagina is called cervix, which is neck of uterus, which opens into a vaginal birth canal, which opens into the vulva, external genitalia. Now cervix, as you can see here, there is a ectocervix and there is an endocervix. So like any other cells which is in contact with the atmosphere or goes through frequent wear and tear, the ectocervix is lined by squamous cells. These are stratified squamous cells, like layers of cells, which are resistant to any sort of infection, resistant to any invasion by pathogens, and protect the vagina and the underlying blood vessels by any infection of sorts. Endocervix is glandular, so it is lined by columnar cells. Here you can see these are columnar cells and these are stratified squamous cells. Now, what is a squamous columnar junction and what is a transformation zone? So what happens is when so since we are born with these reproductive structures, not everybody, but in general population, when a girl is born with such structures, when she matures, the HPO axis, the HPO axis matures, and with that HPO axis, estrogen gets produced in the body. Now, under the influence of estrogen and other factors, and this squamous cells of the ectocervix, and there are columnar cells. These squamous cells start moving inwards. Okay, so here you can say this is your area columnar epithelium. I'll draw it like here, this red area. Okay, then squamous epithelium, brick-like structures here. And under hormonal influence, these squamous cells start invading they start taking over the columnar epithelium. Now this is known as squamous metaplasia, areas of metaplastic squamous epithelium. Now when this happens, so initially, like imagine a pavement, there is, I will draw it here, there is sand here and you are laying bricks. When you start laying bricks on this sand region where sand is, and you start going forward, imagine this is your os. Os is this opening here, this is os. When you start moving in this direction, this line, this is your original squamous columnar junction. And once it starts moving in the direction of the os, imagine it stops here. This will be your new squamous columnar junction, and this area will be the area where the metaplasia has happened. This will be the area of squamous metaplasia known as transformation zone. So now you understand the difference between squamous columnar junction and transformation zone. Transformation zone is basically the area where squamous metaplasia has happened. So it's not a line of sorts. It is an area between the original squamous columnar junction and new squamous columnar junctions. That's why when we take pap smear, there are 3 areas. It's ideal that you take it from transformation zone, this region. But if you're not able to take it, you can take it from your squamous, either this squamous columnar junction, this new squamous columnar junction. So that is the second best site from where you should take the pap smear. And as and when later we discuss, I will tell you the role of how HPV invades this area and leads to some precancerous lesion and how cancer comes to be. Okay, and okay, so now as you have seen, I told you that this is under the hormone, this is under the influence of the hormone estrogen. So estrogen is not constant in our bodies. During menarche, it's different. After menopause, the levels of estrogen are different. So this whole transformation zone, this region is dynamic. It moves. It's not the same. So initially when estrogen is more, this your endocervix will move out. More columnar cells will be out. So this reddish area that you are seeing, let me erase this. This reddish area under the influence of the hormones will be outside more. So it can be after menarche, pregnancy. This will be outside, but it will go out. But when there is no hormone, after menopause, this area will recede inside. So like you see here. Now under the influence of this hormone, this will come outside. So you will be able to visualize all, and this is your squamous cells, imagine. So you will be, transformation zone is visible. But if this area recedes inside, and transformation, this squamous cells will come, so the transformation zone has also gone inside with it. So that is the role of hormone in this. The transformation zone keeps on moving. That's why pap smear, later I will tell you. Okay, let me not confuse you here. Just remember the transformation zone is a dynamic zone, and under the hormonal influence, it keeps moving. Okay, now the types of transformation zone, actually, I want to explain it later, but okay, now since that it has come here. Transformation zone, type 1 is the whole of the transformation zone is visible. This transformation zone is visible. Nothing is inside. Okay. This is the upper limit of visibility is here, and see the transformation is here. So you can see it. When you do a perspeculum, you can clearly see it. Type 2 is the transformation ka upper limit of visibility is little inside the endocervix, but you can still visualize columnar epithelium. This. columnar epithelium is there. Here little columnar epithelium is visualized. So when you will see this dark red area is more. Here dark red area is less, but you can still visualize it. Here no dark red area. Basically the transformation zone has gone in. You're not able to visualize the columnar epithelium. So that is type 3 transformation zone. Why am I telling this? When we are taking pap smear, although we may not realize it's ideal to take it from type 1, type 2. You can take from type 3 also. You will not be able to. Ideally you should take from everything. But the more conclusive results will come from type 1, type 2. And type 3, you cannot do colposcopy. So I will explain on it later. So what do you mean by dysplasia or cervical intraepithelial neoplasia? Dysplasia or CIN, also known as squamous metaplasia. Squamous intraepithelial neoplasia. So in simple words, see, these are your squamous cells. These are your columnar cells. This area in between here, this is your squamous columnar junction. Nothing is there. Now over time these cells will start to take over. See, they have starting to take over and this becomes mature. This whole is why squamous cells have taken over. So squamous metaplasia has happened here. Now squamous metaplasia is a normal change. It's not neoplastic. It's not pre-malignant. It is expected. But sometimes due to various factors which I will describe later, this can become dysplastic. The dysplastic is an old terminology. We don't use it anymore. But previously it used to denote that cells would become irregular. The nucleus will enlarge, nuclear atypia. There will be multiple nucleoli. Such changes, like cells would become abnormal. Now in modern times we don't say dysplasia, we call it cervical intraepithelial neoplasia. So CIN is of 3 types: CIN1, CIN2, CIN3. So when do we see dysplasia? So basic screening modalities, your pap smear, your liquid cytology, or this not HPV, visual inspection with acetic acid, colposcopy, or these reports you get to see CIN. So now basically CIN, CIN2, CIN3, LSIL, HSIL, these are multiple things. Let us not get confused with this. So what happens is, when you take a pap, this is to see the epithelial cells. Now epithelial cell abnormalities. So what happens is, you can get normal cells. Let me just explain it now only. Okay, so when you take a pap smear, okay, you can get, I will explain this later. When you take a pap smear, you can get non-neoplastic findings and you can get epithelial cell abnormalities. Non-neoplastic signs can be squamous metaplasia, like I had explained, keratotic changes, tubal metaplasia, atrophy, pregnancy-associated changes, or any inflammation, any follicular cervicitis, any IUCD if is there, changes later there, glandular cells post-hysterectomy can be seen. So these are non-neoplastic findings. Then epithelial cell abnormalities could be squamous cells and glandular cell type. In squamous cells, you can get atypical cells, you can get LSIL, and you can get HSIL. Atypical cells can be of undetermined significance, and atypical cells which you cannot exclude HSIL. So what am I saying here? When a pathologist on that pap smear slide see multiple cells, what he will see is, first he will be able to tell you that cells are neoplastic or not. So he will tell you non-neoplastic. Now imagine if he has any doubt, he will say that okay, yeah, I'm seeing atypical cells. These are usually not seen, but I cannot determine their significance, undetermined significance. Then you will have to correlate with the patient's history, patient's age, any other risk factors, and then take the call. He can also say that okay, I am seeing atypical cells, that is there, and they definitely don't look like any low grade change. I am not able to rule out any high grade squamous intraepithelial lesion. I am not able to rule this out. These cells are atypical. There is definitely a problem. I am trying to say, you know how you when you're not sure of something, you try to rule out the malignant characteristics. In this, he's not able to rule this out. So he will say, cannot exclude HSIL. Then there will be, then another he will say, there is squamous intraepithelial lesion. Intraepithelial lesion. Now this can be low grade or high grade. Okay? When it is usually high grade, it can be moderate to severe. So now after this is when you are seeing just cells. So on the cervix, cells were there, loose cells. You know how our body, everything sheds cells, dead cells come above and they are shed off. So when you took a pap smear, you collected these cells, put them on the slide and you studied. In this, you will not be able to tell the invasion. Okay, you will not be able to tell if these changes are going till the lower layers. You know how that is how we define a lot of cancers, whether this is external, innermost layer, whether these cells outside that you have collected and you have seen, whether these cells are present there up to the deepest layers. Whether these cells are present up to the deepest layers. For this, you will need biopsy. Biopsy is the definitive test to tell whether any type of precancerous lesion or cancer is present or not. Now, what does this LSIL, HSIL? Now you will ask me, you are saying, okay, we've done pap smear. We are saying LSIL, HSIL, and you're saying we need to do biopsy also. Is there a way that we can correlate these? So you know how sometimes आप किसी की चाल देख के उसका character बता सकते हो? So this is like that only. When you are getting these findings on pap smear, what they correlate is, so in terms of LSIL, HSIL, CIN 1, 2, wait, I'll tell you, explain it later. So as we were here, what does this tell us? One second. Yeah. So now, as I told you, now I have told you that on pap smear on this test you will get these findings. But what does that mean? What does those loose cells that you have collected mean? So on pap smear you have gotten, like I told you, atypical cells, undetermined significance, or cannot rule out HSIL is a different entity. But imagine you had get LSIL and you have gotten HSIL. When you will take biopsy, usually LSIL will be CIN, cervical intraepithelial neoplasia 1, and HSIL will be CIN 2 and 3. So what do you mean by this 1, 2 and 3? 1 means that in the cervix, the lower 1/3 layer is involved. CIN 2 means your lower up to like middle 1/3 is involved. And this means up to either this much, it's coming up to 1/3, or full is involved, but it has not breached basement membrane. Now CIN1 is an insensitive histological marker. What does that mean? That means CIN1 does not tell you whether there's a problem or not. Okay, you have to do other testing to make sure that there is an abnormality, and usually CIN1 can go back also. So the management of CIN1 is just usually follow up. Okay, the risk of malignant transformation of CIN1 is only 1%. Now CIN2 and CIN3. CIN2 and 3, like I told you, are HSIL. CIN2 is usually told that is a mixture of 1 and 3, and to definitively tell how much potential it has for malignancy, you have to do immunohistochemistry, P16 and all. In the new FOXY guidelines, they have given some tests. Actually, I'll just show you. See, these biomarkers, the Federation of Obstetrics and Gynecology India recommends these P16 tests. So what you can do is, if you like on pap smear you're getting you've got an HSIL, and then you did a colposcopy biopsy and you got CIN2. Now we cannot be sure how bad CIN2 is, so you get a biomarker P16 done. So when you get it done, And if it comes positive, you can say it's more chances that it's more likely to convert to a malignant state, and you can treat it. The likelihood of conversion of CIN2 to malignancy is 5%. Okay, and CIN3, it is a true precancerous lesion. Okay, that means you have to treat it. You have to treat it. Also, these CIN1, CIN2, these are biopsy proven. So next step is management only. Now, second thing, after acquiring HPV infection or any risk factor, it takes around 5 years for it to become CIN3. And from CIN3 to invasive cancer, it takes almost 30 years. That is why I hope you guys remember that in community medicine we had read, or when we do tests which are sensitive, specific cancers, diseases which we can screen, which have a long I forgot what it called, long manifestation time, that the incident, the injury to the outcome, it's taking a longer time. You can able to, I'm sorry, I'm not able to remember the correct word, but when there is a long disease interval, you can screen these diseases. There are multiple points where you can catch the disease before it becomes untreatable and treat it. So that definitely decreases the burden to the society. Now you'll be like, okay, I randomly just told you guys about what HPV is. So HPV is human papilloma virus. It's a circular double-stranded DNA. Like here you can see double-stranded DNA. There are multiple types. There is 6, 11, 16, 18, 31, 33, 52, 58, multiple types. There are more than 100 HPV types are available. Out of it, 16 and 18, 70% of all cervical cancers they cause. And 16 is the most common cause of cervical cancer. Okay, so now this has 2 capsid proteins, L1 and L2. And then it has these E1, E2, E3, E4, E6, E7, these other proteins, the areas in its DNA, which when it gets translated form certain proteins which gives it the superpower to induce cancer. So what happens is you get infected by HPV. It's mostly sexually transmitted. That's why the whole awareness about giving HPV vaccine before the onset of sexual activity and all of that. So it's definitely sexually transmitted. There is also something called congenital HPV infection, which a girl child or like a male child also can get during birth. So it infects the epithelial cells in the cervical mucosa. Now this HPV DNA integrates itself into the cellular genome. The Harold Zurhausen was the first person to find the HPV DNA patient's DNA. Okay, it incorporates itself and it infects. There will be like some sexual during sexual activity there is microabrasions or something, and this will get incorporated into the basal layer. It will start from the basal layer and come upwards. And also it will not go into the bloodstream. It will not cause any viremia. Hence there will be no local immunity produced because of it. That's why people do not develop immunity to these viruses. So it will infect the basal layer and then it will cause these changes. Now 90% will heal within 2 years. That means viral clearance will happen. So that is why when we do pap smear, we repeat it every 3 years. Or when we do HPV DNA testing, we repeat it every 5 years. Why? Because most of it gets cleared. Or sometimes if HPV DNA comes positive, we repeat it after 2 years. Why? Because within 2 years it gets cleared. So second time if it comes negative, you can tell that it has cleared off. Then sometimes when it doesn't get cleared off and there is viral persistence, it persists, it can cause invasive cancer. 0.8% develop cancer. Okay, so this is what I wanted to tell. Are all HPV bad? Well, there are some which are lesser of the evil, but yes, they definitely cause something or the other. So like I can tell you, HPV virus, there are low risk and there is high risk. Low risk is 6, 11 and high risk can be your grade 1 carcinogens. That means it will definitely cause some problem. 31, 33, 45, 52, 56, 58, 59, and and there is 168 type, which is not grade, sorry, class 2A carcinogen. Now this low risk will cause your genital warts. Sorry, my battery is low. It will cause genital warts. It can also cause exophytic condylomata acuminata. Exophytic condylomata acuminata. Now this is the one which usually causes a latent infection and most likely to get cleared off. Hence they are low risk type. But the thing is, if somebody has a low risk, when you do HPV DNA testing and they're getting a low risk HPV infection, they're also likely at some point, that's why you need to screen them also. You can't be like, oh, you have low risk, it's okay, no problem. No, you have to counsel them accordingly. That's if they're exposed to low risk, there is a possibility they might later, if you don't counsel them properly, if you don't advise that during sexual activity barrier contraceptive should be used, if you don't advise against multiple sexual partners or other things, high risk lifestyle, they might end up getting the high risk variety also, which can lead them to develop cancer later. So your counseling is very important. Now high risk, like I told, it can cause multiple. There are 6 cancers which it can cause. Okay, like I told you, cervical cancer is there. It can cause vulval, which is external genitalia cancer, vaginal cancer. It can also cause oral cancer. It can cause penile cancer. It can also cause anal cancer. So you can see these are all high risk sexual. So there is orogenital, anogenital transmission. So even gay and lesbians, people with same-sex partners are also likely to get these. So when you counsel, it is important that it's not just like a male to female or the thing. It don't affect female. It can also affect males. It can also affect oral cancer, cause anal cancer. So you have to counsel appropriately. Now obviously prevention is better than cure. So we have 2 strategies. We can vaccinate and we can screen. Now for vaccination, I can't. Yeah. I think I've spoken for quite some time. This is my first session where I've spoken so much. Okay, so for now, I hope you have understood the pathogenesis, the pathophysiology of this. 3 things if you can remember. You have to remember there is something called a transformation zone, which is dynamic. There is something called, which has squamous metaplasia. Sometimes due to multiple risk factors, which can be, I did not tell the risk factors. The risk factors can be HPV infection. This is the most common, most important, due to sexual activity. The earlier the onset of sexual activity, the earlier you will get exposed to these viruses, and the longer they will be in your body, and the longer they are, the more likely they are to cause any cancers. Second, HPV. Then there can be conditions which are estrogen related. Basically estrogen as in like early pregnancy, like first pregnancy is earlier, because then the transformation zone will move out, and then since transformation zone is outside, and also during vaginal delivery there is trauma, there is tear later on, the this viruses can invade and cause cancers prolonged period of time. Then this early intercourse, I'll come here. Then OCPs, although it's not a proven factor, but I read somewhere that it's the causal relationship has not been established, but this is definitely a key point. I think more than 5 years usage of OCPs is likely to cause this. Again, these are hormonal, so could have a relation, but I'm not sure. If you guys know any data on this, please let me know. Now, third thing that you should remember is the spontaneous clearance of these. So spontaneous clearance, viral persistence, which is more likely to cause these cancers. Then when you remember this, you will remember the HPV. Like I said, you will remember the HPV virus. You will remember the E6, E7. This E6 will suppress P53, cause upregulation of this enzyme called DNA methyltransferase, methylation of DNA, and this is anti-apoptotic. So usually the cells should die, but it will cause them to become immortal. Then this E7 will inhibit your retinoblastoma gene, and that again will cause the cells to become immortal and cause carcinoma. So this you will remember. Now third thing you will remember, the correlation of what is LSIL, HSIL, what is CIN1, CIN2, CIN3. LSIL, HSIL, these are pap smear, epithelial cells abnormalities detected on pap smear superficially. CIN1, CIN2, CIN3 is told on biopsy. So this. Now we were coming on prevention is better than cure, vaccination and screening. So I want to do a separate video on vaccination actually, where I will discuss everything in and out vaccination related. If I start going into it now, because it's a big topic and there is a lot of misconceptions about it, so I wanted to do it properly, but here I will just go briefly into it and try to explain it. Okay, so now this is derived from the L1 capsid protein, like this one. This L1 capsid protein is used to make the vaccine. Since it's a capsid protein and no DNA, hence they are very safe, and risk of vaccines causing HPV infections is not there. Okay? The effect is when you give this, it causes humoral immunity. Humoral. So it will protect further from, like it will protect from the infection from the same type. Like that is why our vaccine Cervarix is 16-18 specific. So they prevent against the infection of 16-18 only. So the more viruses we discover, maybe the more we can incorporate them into vaccines and get protection. So humoral immunity they develop, and that is how you get protected. That is why if you have been infected by that specific subtype of virus and then you receive the vaccine, it does not prevent it. So if already infected, vaccine no use. But does that mean you should do HPV DNA test before vaccination? No. See, the whole point is you have to universally vaccinate everybody and you have to universally screen everybody. For every person that you're going to vaccinate, if you sit down to do their HPV DNA testing, you're actually causing, there is a lot of burden that you're causing. And even if they are infected by that particular virus, vaccinating does not cause any harm. No harm. So we assume that okay, everybody, that is why initially it was said that it's better to give before the onset of sexual activity, hence people were less likely to get infected from the viruses. But now actually we have expanded and we can give this vaccine even after the onset of sexual activity. So what is the age that now is being recommended for vaccination? So previously it was, I don't know how much, but now 9 to 26 years, and in which also early years, I think 9 to 11 years of age, I'm not even sure 9 actually, I think 10 to 11 years of age is considered the best, but you can give the vaccination from 9 to 26. And don't worry, if you're above 26, you can still get the vaccination. So above 26 also, up to I think 20, up to 45 years, based on the physician's discretion, you can get the, okay, we do not know that how much effective it is, but there is no known proof that it causes any harm. So you can definitely take up to 45 years based on physician's discretion. Otherwise 9 to 26 is the ideal age. Now can you give it at less than 9-year-old? No, we should not give this. Under no circumstance we should give this below 9 years of age. And can we give it beyond 45 years? There is actually not point. According to WHO, after 50 we don't do visual inspection, and after 65 we stop screening altogether. So at 50 giving this vaccination actually does not make sense. So you will say, why at 45, why not at 50? I do not know. But 9 to 26 is the ideal age that they have given. Now we have 3 types of vaccines: Cervarix, Gardasil and Gardasil 9. Cervarix is a bivalent vaccine which prevents against 16 and 18. Gardasil is a quadrivalent which prevents against 16, 11, 16 and 18. And Gardasil, it's a 9. It's a nonavalent vaccine which prevents against all these types. Now, so that means 16, 18, like I told you, 16, 18 causes invasive cancers. But does it protect against warts? No, it does not. Gardasil is the one which has 6, 11 and it actually prevents against warts prevention. And this too, like you said, it prevents against all your oral cancer. No, actually it does not. Oral cancer is not caused by 16, 18. So this protects only against 16 and 18. Cervarix again, CA cervix. This again warts and then CA cervix. This protects against oral, penile, all the other cancers that I told, warts and CA cervix. Okay. Now imagine if somebody has started taking Cervarix vaccine and now they are like, okay, there is Gardasil, can they take it? Yes, they can take it. Before that, I'll just tell you what is the dose recommendation. So now in the current scenario, beyond 21 year, we are giving 2 doses, 6 months apart. And below that, 9 to 14, I think up to 15 we are giving, I'm not sure actually, wait, let me just clarify this. Yeah, up to 21 years, more than 21 years here, you are giving 2 doses, and less than 21 years, you are giving 1 or 2 doses. Any is fine actually. You're not giving, now this is important rule, 3 doses. Why not giving 3 doses? Why? Because it's a waste of vaccination, and the only scenario where you give 3 doses is HIV. So if you have HIV positive person and you want to vaccinate them, then you will give. Okay, so this is what we are doing. Now, second thing, if somebody has taken Cervarix, Gardasil, can they move on to Gardasil 9? Imagine they have taken already 1 dose of Gardasil. Now they're like, but there is a new vaccine, Gardasil 9, can we take it? Yes, they can take it. Should they repeat both the doses, or can they start from the same one? They can start from the same. So if they have taken one, they only need to take 1 more dose of Gardasil. Now imagine if they have done a full course of Gardasil. Can they take Gardasil 9? No, there is no point and it is not recommended. Okay, so this is about vaccination. I hope you understood something. Now I think today's session this much is enough. Tomorrow's session we can do screening more in detail. I hope you guys enjoyed it. I will continue teaching about the screening modalities tomorrow. I don't want to make these sessions very heavy on you also and me also. Like after a point I feel like I'm just repeating and repeating. So to summarize this, we'll just do a quick summary and some things that you can yourself think about. First, that precancer, we are talking about precancer of cervix. Second, what is the squamous columnar junction? What is transformation zone? What is squamous metaplasia? Now, since you will remember this, you can ask yourself, what is the difference between dysplasia versus cervical intraepithelial neoplasia? Next, you can ask yourself, what is LSIL, HSIL versus CIN 1, 2, 3. Next thing you should ask yourself is, what are the risk factors of developing CA cervix or precancer lesion? Something about HPV DNA. After HPV DNA, we can talk about prevention, in which we have spoken about vaccination, and tomorrow we will speak about screening. Hope you enjoyed. If you did, and if I was able to make any sense to you, please subscribe to my YouTube channel, press the like button and share the videos. I will try to upload as many videos as possible, and I will try to bring up-to-date content. So if you have enjoyed this, thank you so much.